Welcome to this very exciting webinar sponsored by Sonic Insights, the makers of Velicare. My name is Michael Betel. I'm the president and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with NAFLD and NASH by advocating for access to approved treatments and care. Today is incredible because we have an all-star panel joining us, all of them experts in the field of liver disease and specifically NASH. Our first speaker is Dr. Maru, director of the Metabolic and Fatty Liver Program and professor of medicine at the University of Chicago. Maru spearheaded the group that worked on the recently published AASLD guidance for the management of NAFLD and is the lead author of the corresponding publication. Dr. Stephen Harrison is chairman of both the Summit and Pinnacle clinical research groups located in San Antonio, Texas, and visiting professor at Oxford University, UK. He is internationally known for his involvement in clinical studies in NAFLD with more than 250 peer-reviewed publications to his name. And finally, closing out this all-star cast, we have Dr. Mazen Noureddin, a transplant hepatologist at the Houston Methodist Hospital. Dr. Noureddin recently opened the state-of-the-art Houston Research Institute. Previously, he was founding director of the Fatty Liver Program at Cedars-Sinai Medical Center. He's internationally known for his research in NAFLD and NASH and is an expert in non-invasive testing and biomarkers. We're going to start with an overview of the AASLD guidance statement document with Dr. Rinella, and that will be followed with the top line results of the two drugs closest to market, resmetirom and obeticholic acid, with Dr. Harrison. Following these two presentations, we will have a super engaging discussion with Maru, Steve, and Mazen and I, so that we can all understand how the NASH landscape is about to change and what we need to be doing to prepare. With that, I will now pass the microphone over to Dr. Maru Rinella for her presentation.
Thank you, Michael, and thank you very much for the invitation. I'm excited to be speaking and having a discussion with these very informed members. So we're going to go ahead and start with just the basic outline and messages of the guidelines that are different specifically from the prior. These are my disclosures. So the goal when we were putting together this document was to provide actionable, rational recommendations based on the best available evidence. We wanted to focus really primarily on evolving fields such as non-invasive testing and therapeutics, and practical recommendations on the use of medications approved for diabetes and obesity were formally discussed and recommended in specific contexts. So the major updates from the 2018 guidance are that the pediatric section was removed and developed into an independent guidance document. We specifically recommended screening for advanced fibrosis in high-risk populations or case finding. We provided a risk stratification algorithm to help clinicians decide who needed to be referred to hepatology in two different contexts of use, the primary care setting and the GI practice setting, and provided specific metrics for the non-invasive diagnosis of at-risk NASH, advanced fibrosis and cirrhosis, who will be the primary targets of therapeutic interventions. And again, touched on off-label use of available meds, and then ended with an optimal care model that we would love to see used across the country. So first, starting with diabetes. So we have a lot of retrospective data that demonstrates that patients with diabetes have a higher risk of fibrosis. This is a prospective study from the NASH CRN demonstrating the same. This was presented at AASLD at this last meeting. You can see that the progression to advanced fibrosis is significantly higher in diabetics. And if you look at cumulative incidence over time, there is a significantly higher risk of people with diabetes developing progression as defined by greater than or equal to one stage of fibrosis progression. So based on actually a wealth of data, we recommended primary case finding for advanced fibrosis in those with type 2 diabetes, those with medically complicated obesity, those who also drink moderate alcohol in the context of NAFLD, and first-degree relatives of patients with cirrhosis due to the significantly elevated prevalence in these populations. So we provided this algorithm to risk stratify. Again, I'm not going to go through it in detail, but in large strokes, there's a recommended primary risk assessment, which starts with FIB-4, broadly applicable, easily done at very low or no cost, and then gives specific recommendations for what to do with varying risk levels, as we called it, for liver stiffness or ELF as secondary assessment. So to summarize, we did not recommend general population-based screening, hepatic steatosis, or suspected NAFLD based on the presence of obesity or metabolic risk factors should undergo primary assessment, and that's with a FIB-4. And again, patients with diabetes or prediabetes or greater than 2 metabolic risk factors should undergo repeat testing. FIB-4 is not a perfect test. It will miss people in an enriched population, actually, particularly in diabetes. So this needs to be recalculated. And as always, when there's clinical risk or risk as determined by clinical impression, you should go for secondary testing. We stopped short of saying that, but that is something that I think is important to remember. And then provided also what has been published as an ELF value beyond which is linked to hepatic decompensation in the setting of advanced fibrosis. I am not going to go through these specifically because we want to discuss mostly, but these basically provide cutoffs for exclusion and high specificity inclusion of to identify those with at-risk NASH using these parameters you can see here: FAST, MAST, MEFib, and corrected T1. And then did the same for advanced fibrosis and cirrhosis to help guide the clinician when they're trying to exclude somebody that has cirrhosis, perhaps for a therapy that's not been shown to be effective or safe, and then to positively identify patients in those categories as well. So just brief clinical pearls. Aminotransferase levels are really still often used, in fact, almost exclusively by primary care doctors and endocrinologists sometimes to determine whether somebody has NASH or not. This is, of course, not a very sensitive test. Normative values are reported by labs are higher than what we would consider to be a true normal. We also did not recommend ultrasound specifically for detection of steatosis due to its multiple flaws. And instead, if there's a desire to accurately detect or quantify specifically steatosis, this is best achieved with MRI-PDFF. So these are basic recommendations on management. We recommended that those who are obese or overweight should be prescribed a diet that leads to caloric deficit. There's the most data on Mediterranean diet, both respect to weight loss as well as macronutrient content is important. Patients should be encouraged to exercise, of course, to the individualized to their abilities, and bariatric surgery is an important option due to its very clear benefits in cardiovascular disease and malignancy, as well as liver-related outcomes. And then I believe, lastly, before the care model is alcohol. Alcohol is an important cofactor for disease progression. We think that really even low to moderate levels of alcohol intake can be impactful, and that this should be monitored on a regular basis. With respect to the care model, it's important that leaving the patient, of course, in the center, that this be a combined effort to best manage with a combination of hepatology, gastroenterology, and specifically diet, nutrition, lifestyle intervention led by a dietitian. This is critical for success. And of course, most of these patients are coming from primary care and endocrinology, and we need to keep working on increasing awareness to show them which patients are at highest risk for progression, so that we can avoid patients presenting with very end-stage disease, which is unfortunately what we see too often. And with that, I guess I'll close, and I will turn it over to Stephen for exciting updates on new therapies.
All right. Maru, thank you for that wonderful lead off and introduction. And so special thanks to the Sonic Insight team for pulling this webinar together, and for Michael for being here to help moderate it, and all the work you're doing behind the scenes and in front of the scenes to help bring awareness to the world and to our patients about fatty liver. I'm honored to be here having this discussion with two of my most favorite people, Mazen Noureddin and Maru Rinella. As was stated at the beginning, these are world leaders in the field, and I'm honored to be a part of that today. So what I've been given the task of is not to talk to you about all the therapies in development for NASH, because there is a cornucopia of them, but really just to drill down on the two that are closest to the finish line: resmetirom, a thyroid hormone receptor beta agonist, and a beta-cholic acid and FXR agonist. So without further ado, let me just jump right in to that. And here are my disclosures. So when we think about approval of drugs for the treatment of any disease, but specifically for NASH, there is the FDA regulatory framework for drug approval. And in the setting of NASH, instead of having to ultimately show how a patient feels, functions, or survives is modified by a drug therapy before it gets approved, the FDA has established what we call Subpart H approval. And in other words, you can use a surrogate endpoint that predicts outcome data and get approval much sooner. You still have to go on and show that you're affecting outcomes, but you can begin to provide the drug to those at risk at a much sooner time point. And in the setting of NASH, this subpart approval involves surrogate endpoints of either NASH resolution without worsening of liver fibrosis, and that's important, fibrosis improvement of at least one stage with no worsening of NASH. Now, there are some drugs in development today where they're looking at both endpoints, but you don't have to have both endpoints to achieve Subpart H approval. Now, we're sitting here having a discussion about this biopsy endpoint in 2023, and I think one of the major focuses of this conversation and many others that are happening around the world as we prepare for our first drugs to be used in NASH is how do we get to the non-invasive assessment? And I think that'll be a big part of the discussion, and Mazen will be a big part of that as well. So suffice it to say, for this particular segment of the conversation, we're really focusing on histopathology because that's the FDA approvable endpoint. So there are two drugs that have announced positive Subpart H results. The first one is resmetirom. We'll talk about that, and then we'll go on to the second drug, a beta-cholic acid. So remember those names, resmetirom and a beta-cholic acid. So first of all, resmetirom. So it's important to realize in the setting of fatty liver that patients are relatively hypothyroid. Their livers specifically are relatively hypothyroid. So let's unpack that for a minute. What do I mean by that? What I mean is that the thyroid axis is disrupted a bit. You're still making T4, an inactive hormone in the thyroid, but it's carried to the liver and supposedly converted in a healthy liver from T4 to T3 through deiodinase. Now, unfortunately, that's not working properly in the setting of fatty liver. You actually get a buildup of reverse T3. So the thyroid gland is making thyroid hormone. It's just not being converted to its active thyroid, the T3 part very well. So that is what this drug predominantly does, is it resets the ability of the liver to process thyroid normally. And when you do that, what you see is improvement in lipid profiles, resolution of fat in the liver, or significant improvement of fat in the liver. There is a resolution of NASH that was seen in the phase 2 trial, and also atherogenic lipids are significantly improved as well. So as a result of the phase 2 data, the programs, if I could call it that, were put into place. And this involved 4 separate clinical trials. One is called the Maestro NAFLD-1 study. And this was looking only really at safety and tolerability, focusing on adverse events related to this compound, given over 52 weeks in more than 1,200 patients at 2 different doses of drug, 80 and 100 milligram. One important feature here is that an additional 180 patients with well-compensated NASH cirrhosis were also enrolled. They comprised the 1,200, but ultimately that is an additional subset of patients that has been very helpful in understanding safety, tolerability, and even non-invasive assessment outcomes relative to that cirrhotic population. Now, about 700 patients from that trial were allowed to roll over into 1 more year of therapy in what we call the open label extension trial. And then ultimately, there was the Maestro NASH program, which was the Subpart H approvable endpoint. Patients were treated for 1 year. You had to have NASH with predominantly F2 and F3 disease to get in, and a liver biopsy at the end of 1 year with a look back to see if patients either met the NASH resolution endpoint or the fibrosis endpoint. The primary endpoint was an either or scenario. And more than 900 patients have been reported out from that trial, and we'll go into that data momentarily. Now, more recently, a well-compensated F4 trial called the Maestro NASH Outcomes Trial hasn't been initiated. The goal here is to put about 700 patients into this trial and follow patients to an outcome. Now, this falls in line with the new AASLD guidance on how to manage phase 3 programs in the setting of NASH, where you have the Maestro NASH program for Subpart H approval, and then you have the long-term outcomes generated in a well-compensated F4 population. Now, if that outcomes trial is positive, meaning that it shows benefit relative to resmetirom compared to placebo in well-compensated F4 patients, then you get full approval for resmetirom, not only for the F2-3 population, but also for the F4 population. And collectively, a total of over 1,500 patients at the top dose and more than 2,000 patients at the lower dose have been exposed to drug and followed for a period of time to support accelerated approval. So what are the top-line results of the Maestro NASH program? This is the pivotal trial, a randomized double-blind placebo-controlled trial where you have to have NASH with an NAS of 4 or more. You can have early stage fibrosis, in particular stage 1A or 1B, but you also have to have an elevated PRO-C3 for those patients to get in. The majority of patients were F3, as I'll show you in a minute, the rest comprising F2. Treatment was for 52 weeks with a repeat liver biopsy. The primary endpoint is, as I noted before, NASH resolution without worsening of the NAFLD activity score, or reduction in fibrosis by at least 1 stage with no worsening of the NAFLD activity score. So that's the primary endpoint, an either-or situation. I misspoke momentarily on the resolution of NASH. It's resolution of NASH with at least a 2-point improvement in the NAS with no worsening of fibrosis. And that is there because earlier work done in the field has shown that to minimize placebo response rates, you want to make placebo have at least 2 things move on the NAFLD activity score. And one of these has to be in ballooning or inflammation. So that's a key point to note. Key secondary endpoint is lowering in LDL cholesterol, not at 52 weeks, but at 24 weeks. And then patients are continuing to be followed to liver-related outcomes at 54 months. So here are the baseline characteristics by intent to treat. Roughly 966 patients were included in this ITT analysis. You see the average age was around 57. The majority were female. And parenthetically, what we know about NASH is the more fibrosis you have, the higher degree of female gender that is involved in that trial. And we also know that holds true for diabetes as well. So the majority of this population is female, the majority is diabetic, and the majority have F3 disease. You see at the bottom, 60 to 64%. So primary endpoint, first we'll look at NASH resolution on the left. And here we see a dose-response relationship, placebo coming in around 10%, which is in line with the other trial I'll show you in a minute with the beta-cholic acid at phase 3. And you see a treatment effect delta of 16 to 20% when looking at 80 and 100 milligrams respectively, both highly significant relative to placebo. On the right, fibrosis improvement of at least one stage without worsening of the NAFLD activity score. You see placebo coming in the low double-digit number, around 14%, again, consistent with the other large randomized phase 3 trial with the beta-cholic acid. A dose-response relationship again seen with a treatment effect delta at the high dose of 12%, both doses highly significant relative to placebo. So basically, resmetirom hit on both endpoints of NASH resolution and fibrosis improvement. What I don't have listed here is there was also a significant improvement of at least 2 points by fibrosis. And that was not a primary endpoint, it was a secondary endpoint. Now, on the key secondary endpoint of LDL cholesterol lowering at week 24, you see a dose-response relationship of 12 and 16% improvement. This is on top of patients that could be on baseline statins, and a treatment effect delta of 17% for the high dose relative to placebo. From a safety perspective, resmetirom is safe and well tolerated with equal distribution of serious adverse events across both dosing arms and placebo. Study discontinuation rates slightly higher in the high dose group, and this was a result predominantly of loose stool or some diarrhea. This tended to occur early in the course of therapy and abated over time. You see a little higher rate of nausea. This tended to be in women, again, more than men, and tended to be present at the beginning of therapy and improve over time. Moving on to beta-cholic acid, this is an FXR. It's been around for a while. It's FDA approved for using FXR to modulate NASH and underlying pathophysiology. We see this works by blocking the rate-limiting conversion enzyme of cholesterol to bile acids, that's CYP7A1, and in so doing, it also works on inhibiting de novo lipogenesis by modulating SREBP1, and this ultimately results in reduction of free fatty acids, lipotoxic stress, reactive oxygen species, inflammation, and ultimately stellate cell activation. When we look at the data from the Regenerate trial, it's a double-blind randomized placebo-controlled trial with a 1:1:1 randomization. So just like with resmetirom, 2 different doses of drug versus placebo. Here, 10 milligram, 25 milligram given once a day. There was a repeat liver biopsy, not at 52 weeks like resmetirom, but at 72 weeks or 18 months in this particular trial. Patients were followed out to an outcome measure. There is no cirrhotic trial being enrolled following patients to outcome to augment full approval. The idea here is that these patients enrolled in this trial will continue to be followed to outcomes. And so there have been some patients on drug now for 8 years in this trial. What I'll show you next are 2 different ways in which the primary endpoint was reached. And the primary endpoint here is fibrosis improvement of at least 1 stage and no worsening of NASH, or NASH resolution with no worsening of fibrosis. So first of all, there was the individual reader analysis. Now, just to clarify that, there were 2 pathologists that read the data on the left. This was the first time the data was originally read out in 933 patients. Each of the pathologists read half of the slides and put together at the end for the total assessment of whether the drug met its endpoint. Now, for fibrosis improvement, you see that it did meet its endpoint for the high dose. The p-value is way less than 0.05, and the treatment effect delta is around 11 to 12% with a nice dose-response relationship. Again, that placebo response rate for fibrosis is in line with the other phase 3 from resmetirom. You remember that was around 14%, here 12. Now, this led to the first submission for a new drug application. Unfortunately, that was not approved. And one of the concerns was around the individual reader methodology. And so working with the FDA, Intercept put together a consensus read methodology here, 3 different pathologists reading all of the baseline and all of the end of treatment slides. And where 2 of those 3 agreed, that was the result that was taken. If they could not agree, then they got on a WebEx or a phone call and looked at the data together and came up with a consensus read. When you look at it this way, the results are very similar: 22.4 for the high dose, 14.1 for low dose, 9.6 for placebo, treatment effect delta around 13%. So very, very consistent, whether you read it the individual reader way or the consensus methodology way, and you see a statistically significant improvement with the high dose, regardless of which way you read it. Now, when we focus on fibrosis and now drill down to whether or not there was a statistically significant benefit in the F2s or for the F3s, you see for the high dose, it was significant for both F2 population and F3, although potentially more accentuated in the F3 population. Now, I really like this slide, but it's a bit different. So let me walk you through this. So here you see a shift in fibrosis stage at month 18. Now, this is not intent to treat. This is taking patients with baseline biopsy and patients with month 18 biopsy. And you might say, well, why isn't that intent to treat? Well, remember, by intent to treat, if you receive a dose of drug, regardless of whether you have an end of treatment biopsy, you're counted in the analysis. Here, we only took people that had biopsies done at both time points. And what you see is twice as many people improved fibrosis with high dose compared to placebo, and a lower number of patients worsened the disease. So that's very, very important. Now, I want to drill down on that a little bit more when I look at some of the non-invasive tests that I'm excited to talk about in the conversation that's forthcoming. Here, we're looking at ALT relative to fibrosis improvement. And you see, again, placebo way to the left in the light gray. Light blue is 10 milligram, dark blue 25, a nice dose response relationship, really seeing a nice robust reduction in ALT of 38 units per liter at the high dose at month 18. Now, when you look at no change, what I find very, very interesting is a very similar dose response manner, but the magnitude of effect change is slightly lower for the high dose and for each of these actually. And when we get to fibrosis worsening, again, a dose response relationship, still hitting 21.7 unit per liter reduction with the high dose. Now, just me, and I would love to have this conversation with my colleagues. To me, this shows that really when we look at ordinal scoring, it's a very blunt instrument. You know, we're seeing positive impact on non-invasive tests that show a benefit besides just what's being seen on ordinal scoring. And this is, I think, why AI digital pathology has been so helpful, because on a continuous scale, I think we get closer to truth around what's really happening. But ultimately, what makes the biggest difference is the change in these NITs, because we're not doing liver biopsies in clinic anymore. So this becomes critically important. Now, when we look at side effect profiles, just a couple things here. There was a hepatic safety adjudication committee. There's a renal adjudication committee. There was a cardiovascular adjudication committee. This data has all been presented before. What I want to just highlight is that no additional hepatic safety events arose. No additional cardiovascular safety events came to light, with the additional follow-up between the first time the data was reported to the FDA and now the second filing that occurred in December. So just to know a little bit more about obeticholic acid, the PDUFA date is set for June 22nd. There is an AdCom set for May 19th, where all of this will be reviewed and adjudicated by the FDA. But it does appear that the safety profile outside of pruritus and gallstone formation has held up with longer term follow-up. So with that, let me say thank you, and I'm going to turn it over to our moderator, Michael, for the Q&A session. Thank you.
Thank you very much, Maru and Stephen, for those really excellent presentations. I would love to have this discussion now, and I got to start off with probably a question I hate to ask, and I got to start with this one though. So, and I look at Stephen because it's your slide in my head that I keep seeing with all the gravestones. So, why is this different? Why are these drugs now changing the paradigm and we're not going to see any more gravestones in that graveyard? Over to you.
Oh, well, I think that's a hope that we all would have, is that we wouldn't see any more tombstones. But I don't think we're done with the tombstones. I mean, there are so many drugs in the pipeline and so many drugs that have shown promise in preclinical work. And what while we have learned a significant amount of how to translate preclinical work into the clinic, we're not fully there yet. But I think at the end of the day, we've learned a tremendous amount from these drugs that didn't quite make it or didn't quite achieve where they wanted to go from a clinical perspective to advance in the field. And that's why I think we're going to begin to see many, many more drugs make it into phase 3 and hopefully hit that endpoint. I mean, I was thinking last night, a drug shouldn't fail in phase 3, right? We should understand what is going to happen in earlier phase drug development. And in phase 3, it should not be about whether it's going to fail or not. It should be about how effective it's going to be, right? So I think, from a patient perspective, something that's very near and dear to my heart is really just the medical ethics of doing clinical trials and making sure that if we're putting people into phase 3, we're really confident that that drug is going to have an impact. And so I think we have learned there, these drugs that are going to fail are more likely going to fail in early phase 2 trials rather than phase 3. So I think the days of selonsertib, simtuzumab, elafibranor, those phase 3 trials not working, I think those are probably behind us, but we'll probably still see a few more in phase 2.
Okay. And Maru and Mazen, what are your thoughts about that?
About whether we're going to see any more tombstones?
Yeah, you think the road is paved moving forward?
No, I don't think so. It's a very
yeah.
heterogeneous disease, and you can get at it in multiple different ways. And ultimately, we're going to end up using combination therapy. I think in most people down the road, if you look at the efficacy of individual compounds, even the ones that are meeting their endpoints, they're not really overwhelming. And I think that combination therapy is going to get us over the finish line. But I'm sure there will be many failures before we have more drugs approved.
Okay. Thank you, Mazen.
I think I'm between, I'm agreeing with both of them. What the 2B now, I think people are very careful with it and how to interpret the results and how to move to phase 3 or not. And even sometimes people are taking even more bold approach, like the aldafermin, for instance. I'll give you an example. Some people argue that they can continue with the NASH and F2 and F3, but they decided to stop, and they're doing cirrhotic trials. So I think we have learned enough to know what we need to advance for phase 3 or not. We learned relatively okay information about the placebo and what happens to them in phase 3 and what's the effect of that. But as Maru said, it's there are multiple drugs. A lot will fail in 2A, hopefully less in 2B, because we learn more, and hopefully none, as Steven said, in phase 3 anymore. And it would rather be efficacy signal if it's really efficacious or not. Otherwise, if we move a drug to phase 3 and it fails again, that means we have not learned for the last decade or so.
Okay,
Exactly.
thank you for that. So let's go with the positive. We have 2 new drugs coming on the market sometime as soon as possible. Is there anything that's still going to keep you up at night if you're thinking about the execution of actually taking the drugs? Obviously there's the reimbursement side of it, but also getting it out to patients and everything that's involved with that. So I don't know who wants to start that, but I'd love to have your feedback on what you think that future is going to be like.
I think we still have a lot of things to do, Michael. I don't know if this is a good example, but I see like metformin/glipizide period coming with the drug approval with an expensive price, not a cheap price. So as you alluded, there will be the price will be a point of question for me. Although the initial ISO report, I think, is very encouraging. And I think the price will be okay, and a lot of payers will be responsive to it. As Stephen alluded, efficacy will be a big thing. So I just want to emphasize we're not done with the NASH field with the new drug approved, and they themselves, they know that they need to combine with something else and keep going until we reach efficacy 100%. I'll stop here and let more problems be solved by Maru and Stephen, but those are the two things that come to my mind first.
Thank you.
I'll just make a quick comment. I guess the ones that worry me the most are really the cirrhotic patients and those with more advanced disease. We will have data. We have some that was reported out and not terribly efficacious, others that are encouraging, but I'm concerned about them because they're closest to having an adverse outcome. But again, I'm hoping that with combination approaches, we will be able to diminish the rate of progression in those patients that already have cirrhosis. Yeah.
I'm going to come at this with pom-poms in my hand, and I will be the cheerleader. And my daughter will be very happy to hear that. She's a cheerleader at SMU in Dallas. So listen, it's time, right? Drugs are on the forefront of approval, hopefully both, if not both, then one. And I don't know how many of my colleagues, and I'm talking primary care, endocrine, and GI colleagues, have said they're holding back until we have an FDA-approved treatment for this disease. And that is identifying patients and linking them to care. And so I think we will have that final object kind of conquered in the near future. We'll have a drug, and we need to build around that the disease awareness platform. All the work you're doing, Michael, all the work that other patient advocacy groups like Donna Cryer and Global Liver Institute are doing, we're going to begin to have people that are willing to listen, both patients and physicians, and we will have our first drug. Is it the final answer? No. I mean, if we link this to hepatitis C, maybe we're a little further along than just PEG and RIBA, but we're not at the DAA therapy. We're not at the point where we're curing 99% of patients, but we're at that period where we have a drug, we have positive momentum, we can carry the message to patients that we have a way to treat, but also there's room to improve. And we've talked about, and we'll probably talk about again, combination therapy, but let's don't be myopic enough to think that it's just the liver we're trying to hit here. People are dying of cardiovascular disease. They're dying of obesity complications, diabetic complications, renal disease. And how can we begin to develop therapies that can really mitigate those additional risks? And the drugs that are going to be approved, particularly resmetirom, if it gets approved, does have atherogenic lipid benefit, I firmly believe, but it doesn't hit on glycemic control. So there's opportunities to continue to improve there. But I'm waving both pom-poms saying, guys, we're here. Let's get the message out and let's build on that. 2023 is a very important year for NASH.
There's no doubt. It is super exciting. I just don't have pom-poms in my hands, but it is, I do think it's super exciting. And
you would look good with pom-poms.
Oh yeah, well, maybe I'll try it later. But in any case, I do think it's a tremendous opportunity because, as Stephen said, people now feel like they have something they can use to treat, but that's an opportunity for all of us, patient advocacy organizations, societies, pharmaceutical industry, to really raise awareness. And I do think that a lot of headway has been made. We now are seeing, mention and guidance on fatty liver disease in endocrine, for example, in the combined guidance document or guidelines, AASLD guidelines, the American Diabetes Association. There's actually now mention in the American Heart. So I feel like the awareness is slowly bubbling up. And I think with the new drugs, we can embellish, we can basically use the excitement about that to raise awareness and stop seeing patients presenting with decompensated liver disease, which is what I see regularly every single week and saw yesterday when they've been cared for by a provider for decades. So
let me add a little bit to that. I guess where I wanted to go is it's a good year. We're going to have medications, some of them with almost no side effects, and they help other features like resmetirom helping the lipid panel, right, Stephen? But I also I want the gastroenterologist and endocrinologist and primary care to keep in mind that we still have other steps in this field. So it's not just to approve drugs. There are GLP-1s in the pipeline, other SGLT2s in the pipeline, and they have been all tried in diabetes and obesity, and they improve cardiovascular. There are also other medications that they're coming for fibrosis, including those with cirrhotics. So one of the problems we had in this field that people were discouraged by the biopsy and its use in clinical trials. A lot of people shied away from sending people to studies to see what is going to be effective. And I just want to let them know that hopefully the biopsy will go away in the next few years. And we have other things in many hepatologist clinics and medical centers that will add to the effects of what is going to be approved and maybe take us to the 100% hopefully cure or 100% control of a chronic medical condition.
Okay, so and thank you, Mazen, for that, and all of you for those comments. So let's go with the positive pom-pom theory. Are we set up for success now with all the referral pathways? We have primary care physicians, we got the specialists. 100 million people probably in the U.S. have fatty liver by the percentages. 7,500 specialists. So are we set up for success yet? And if we're not, then what are the priorities you think that we have to focus on first?
Yeah, I don't think we are completely set up for success, at least because just looking at the United States, we don't have a national strategy per se. So I feel like we can do what we can do from a societal level. And I think there's a lot of work to be done still. And the excitement for it is growing. So I think that we are moving in the right direction. Awareness is increasing, but I don't think that if everybody suddenly started to do what we're asking them to do, which is case find in high-risk individuals, I think that we would be overwhelmed. But I think that it's not going to happen like that. And I think we will slowly be able to adapt our practice, with time.
On the other hand, we have now 4 to 5 guidance, thanks to you, Maru, and the rest of the group, of having, I think, outstanding AASLD guidance. And I know it took a lot of work. There was the AGA, there was the ACE, lean NAFLD AGA, and EASL. And they are consistent now. We used to say different things, and the message is clear: type 2 diabetics, pre-diabetics, 2 metabolic risk factors. I'm just going to say it's malpractice not to screen them. It's malpractice not to look for non-alcoholic fatty liver disease. And guess what? All of these 5 or 6 now, they all start with the same thing. Maru addressed its limitation, which is the FIB4, and it might change in the future, but for now, it's cheap, effective, and available, and we need to start with it, and then move to ELF or imaging study to pin down and narrow the fibrosis stage in these patients. Having medications will infuse energy and let people use these algorithms and guidance more effectively, because although we always had things to do for these patients, now I guess what they were asking for, which is FDA approved medication, will be there very soon. So hopefully with all that, we will have a jump start to a much better place than we were in 2022.
Yeah, I agree with that. The caveat I would say is really the idea with these first guidance documents, whether it's AGA, AASLD, EASL, ACE, is we want to get something out to the frontline provider to bring awareness about how reasonably simple it is to make this diagnosis and link them to care. But I mean, Ken Kuzi says it really well. We want to build muscle memory at the primary care level for when you have a risk factor or you have diabetes or fatty liver, elevated liver chemistry test. We want patients to have a FIB4 done, but there's a lot that we need to improve on the diagnostic front as well. So just as we're improving on drug therapy, we need to continue to move the ball down the field in enhancing our diagnostic capabilities so that we have better and better tests to provide our providers to make the right diagnosis. And once these drugs are approved, they're not going to be approved for anybody with fatty liver. They're going to be approved with people that have at-risk NASH. And yes, the guidance documents guide us towards those at-risk NASH patients, but they do it in an algorithmic fashion. Wouldn't it be great if down the road we have a simple test, a one-stop shop test that gives us that answer without having to go through an algorithm to improve sensitivity, specificity, and eliminate the indeterminate zone? So yes, we're starting from scratch. We're unified in our front in the way that we need to tackle this. Now we need big time campaigns to get that message to the providers. And there's no easy way to do that. And there's no one way that works better than another way. You know, just think about if you are planning a meeting and you have your team that you need to get that message to, that you're having a meeting on Friday at 10 o'clock, you can send an email, you can post it in the bathroom or the hallways of the elevators, you can do all kinds of things, but there's still going to be people that don't get the message. And they're going to say, I never heard of our meeting at 10 o'clock. So the point is, we can't just rely on the pharmaceutical companies to put out a disease awareness campaign. We can't rely on Michael and GLI and all the others to build the campaign. We need to do this in a unified way through multimodality approach to get this guidance document out to people, to get that the fact that therapy is coming to the forefront in at-risk NASH patients. And we'll work on it from there. But we have a Herculean effort in front of us. There's no doubt.
Stephen, when was the last time you saw a sign of a meeting in a bathroom?
Hey, I'm just saying, you know.
He's the one who puts them there.
That's right. Maybe I'm.
That's why nobody comes.
I mean, you see Post-it notes all over the place about meetings, you know, elevators in particular, right?
That's so true.
We have a question that came in. We've covered, I think, the topic in general, but I'll reword it a little bit. When physicians are ready and drugs are available, and they have all of these patients, and they have now the statements available and all of the non-invasive testing available, how are they going to decide who to start on treatment first?
I guess I can start, and then maybe Stephen and Mazen can jump in. So I think it's going to depend a little bit on what medication we're talking about and what the limitations and what it's approved for. So if it's a drug that's approved through the disease spectrum from NASH through to cirrhosis, I think that it's going to be a little bit easier for the primary care community to be able to tackle that. I think that if a drug is approved with significant limitations, then it's going to be a little bit more nuanced. It's going to require a little bit more training, and it may initially reside in the hands of just hepatologists, gastroenterologists that have strong interest in the disease. Maybe I'll just lead it off with that.
Along the same line, I'll get a little bit to more details, which is Stephen mentioned the at-risk NASH people, and this is historically on biopsy NASH and F2. Sometimes we call it the phenotypic NASH. And the general concept is clear. You need steatosis, you need stiffness that is equivalent to F2 and higher on a blood test or imaging test, and you need some elevation of liver enzymes, most likely AST. So again, I congratulate the AASLD guidelines. They mentioned some of these at-risk NASH scores, but I think when the drug comes out, it will have something in the label to direct you to which patient you need to see. So some of these scores plus steatosis as well as stiffness on imaging that equivalent to F2, and I'll say elevated AST. Those are in general the general concepts that led to these scores, that led to us screening these patients for clinical trials and biopsy them on the clinical trials. And I think one of the questions also that came up is, would the payers require liver biopsy? And Stephen and I had this conversation. I think what we are very comfortable and confident that will not be done, that the payers will push you to do liver biopsy. Indeed, they're pushing the opposite direction. And I think with some good confidence on the data that in the field, the staging and undefining at risk NASH is, I think, is there. Monitoring therapy, I'll throw a quick word on it. To me, what I want to watch is what the resmetirom and the obeticholic acid they come out with this sub-analysis or subsequent analysis after they publish the results, and they tell me like how their NITs responded to the histology, at least for now, until we have outcome data in the long term.
Yeah, I'll just add on the ease of use of accessibility of these drugs is really going to be predicated on pricing. If the price is right, so to speak, then the payers are going to be more liberal in their ability to get access to the drug. And I think it's pretty clear that at the likely projected price point of this drug, it's going to be a prior auth to label, meaning whatever the label is for that particular drug, insurance companies will do a prior authorization to that. Now, that's good news in a way, because if you get prior authorization, you're good for 1 year, which means you don't need to assess utility of the drug necessarily short of 1 year, which will help in getting the word out about the utilization of the drug. But the other thing that's going to be important as these drugs come to market is the health economics data that are generated from the use of these drugs. Are you able to mitigate polypharmacy in these patients? Are we beginning to show a reduction in liver transplant, hospitalizations, readmission rates in 30 days? And unfortunately, the answer to that probably is not yet with these new therapies. If you look at hepatitis C treatment, we had to get into the 60, 70, 80% cure rate before we began to see a dramatic decrease in liver transplantation and some of these issues with decompensating disease. It doesn't mean that we won't see it sooner, because in NAFLD, there's many, many more patients than hepatitis C. So we might see this impact earlier, but we have to start somewhere. And that's the exciting thing. We'll have our first potentially approval this year, and then we'll build off that. But these are some post hoc analyses and some follow-on data that will help continue to build momentum for drug therapy in NASH.
Thank you. There's a ton of questions, so I'm going to kind of combine a couple just because of the time that we have available. So with regard to initiation of therapy, are you able to say, just from maybe what you've heard, what a non-invasive test, imaging or biomarker test might be required to start treatment? And the second part of the question is treatment going to be restricted to specialists, or can primary care, like what happened in hepatitis C, you referenced, Stephen, it's changed over time. So do you think it'll start where the specialists are the only ones that can prescribe? And also, again, about which tests are going to be required? Those are the two questions that I'm
real quick, I'll make a comment and then pass it on to my colleagues. I think it again comes back to pricing, and what has been made clear to me, at least in the one meeting I've had with payers, is that they are going to reflect back on the key opinion leaders and the guidance that have been put forth and published, which makes me think that they will fall back on the AASLD guidance document, the AGA, and the ACE. If you're meeting those criteria, in other words, an indeterminate or elevated FIB4 followed by a imaging study consistent with more advanced disease, I think those people will be the low-hanging fruit that get offered drug. And where it starts really depends on the price, because the price will determine how restrictive the payers are going to be in getting access to that drug. The lower the price, the broader the application. The higher the price, the more restricted.
Right. And I'll add to that too, I think it also will have to do with the side effect profile of the drug. If we have no safety issues and we have safety in cirrhosis, then I think it'll be more broadly utilized as an additional factor to the price.
Not have much to add. Those are great comments.
Do you have thoughts about how we might monitor the success of treatment?
I mean, I'll go back, Michael, to what I said. If you ask me what is the best way, we do it every day in our clinics. We monitor ALT, we monitor imaging studies that we have in our offices that detect steatosis and fibrosis and see where they move. And what you ideally want to do is look for serial tests not like ALT between 2 points because they fluctuate, right? So you want to look at ALT over 3-4 visits, over 6 months to 12 months. You want to look at steatosis quantification. You want to look at fibrosis quantification. And preferably, if they all move the right direction, that means you're heading the right direction. Now, the resmetirom data and obeticholic acid data, they should inform us what is the best and what's most accurate, and hopefully, or maybe which combination of tests that we need to look at to predict best response to therapy. Maru put out already a paper from obeticholic acid where she showed ALT, AST, FIB4, and imaging study as well as ELF. They all headed the right direction with improvement in histology, and the wrong direction when the histology worsened. So we need more of these data. Resmetirom, they have additional data in addition to ultrasound imaging and liver enzymes. They also have MRI-based tools. So that can be another, not like alternative, another way to look for response to therapy.
And with respect to with respect to secondary assessment, I think it's important that, you know, even though we focused on transient elastography in our document and actually offered ELF, which is not really the way that the test is approved, other methodologies of liver stiffness are also going to be, you know, again, it depends on what you have available at your fingertips. If you have, you know, MRI or MRE rather, if you have, you know, Velicure, if you have ultrasound RFI or whatnot, you use what you have rather than, it doesn't have to be one or another, I guess I would say.
And I would just add to that, we need more point of care tests. We need these tests to be in the clinic where we can use them as an additional vital sign for improvement. And just to echo Mazen's point, the trend is your friend in medicine. Okay. So just remember that it's 2 time points do not make a trend, right? It's following these people over time, just like we do in clinical trials where we're looking at ALT at 12, 24, 36 weeks. You know, you want to begin to see a gradual decrease in liver chemistry test. You want to see a decrease in liver stiffness. You want to see it, or whatever you're measuring. But I would advocate for those people that are potentially listening today, we need better point of care tests. It's not just a blood-based test. We could improve on our imaging modalities as well. And so I do think as we get therapies on board, we're not going to want to be sending people necessarily to MRI units to have assessments done. And quite frankly, if you're in a rural environment, it's hard to get to an MRI unit. But if you have a point of care test, and many are being developed now, that would be very helpful.
Okay, thank you, Stephen. We have 2 minutes left, and I want to stay on time. And I want to end really by asking each of you just what message would you give, I mean, to everybody, but primary care are the ones that are going to be seeing most of these patients first. And so, you know, what would you say to them so that it's not overwhelming and they can actually start that journey?
Check a FIB4.
And if it's more than 1.3, refer to us. We're going to have medications and we have other options in clinical trials.
Or get liver stiffness testing before sending tests if you can. That'd be better. But...
Yeah.
Stephen, you know what the last word?
Well, look, it's hard to beat the word of Mazen and Maru, but I agree completely. And just more than anything else, taking an extra moment or two to note if a patient is at risk for the disease.
Thank you for that. Thank you, Stephen, Mazen, and Maru, for your presentations and this discussion. For sure, Sonic Insights for having this wonderful opportunity, and for everybody who attended today for coming. And good luck out there. We have a lot of work to do together, as everyone said today. Thank you so much.